All right, everyone. I am back with another one of my scenarios that I think will be so helpful for you, whether you are even practicing anesthesia. I would love to hear if anyone is a CRNA and is practicing. I would love to hear what you would have done and what your thoughts are. I love connecting with people in the community. If you are in CRNA school, and this is also great for care plan reviews. So definitely check this out if you come across any one of these diseases, comorbidities that we're going to chat about. And if you're just curious to know, what we do in anesthesia. Like it's a very mental, it's like a mental kind of job a lot of the time. So I actually had this scenario up in my Instagram stories. You can go to see previous questions and scenarios that I post that people comment on, and it's great critical thinking underneath my highlights at Amanda K CRNA on Instagram. A lot of that stuff is there. And then all my other videos are on my Facebook page, YouTube. I will put all the links below if you like this kind of thing. Okay. So I felt like this needed more than an IG story. I really wanted to be able to talk about this because I think it'll be so helpful. So you have a 66-year-old patient. We're suffering from osteomyelitis. We're having issues with their feet, their lower extremities, and ends up needing a BKA below the knee amputation, unfortunately. Okay. So this is the patient's history. They have a history of post-op nausea and vomiting in the past. They have dilated cardiomyopathy, high blood pressure, pulmonary hypertension, COPD. They are on 4 liters nasal cannula chronically 24/7 around the clock. Their BMI is 60. They are bedridden, are not getting up and moving around at all. They also have hypothyroidism. They have Sjogren's, which I did a whole video on this, so definitely check that out. Fibromyalgia and diabetes mellitus type 2. Okay, so what's your plan? What are you going to do to anesthetize this patient for a BKA? All right. In this particular case, the patient had been in the hospital. And so that's always a good thing. So that when your patients are in the hospital, it's like you can just look at everything right then and there. If you have somebody that's coming in outpatient, obviously anybody with this extensive history, need the data. You need to be able to see what is a really good picture like of this patient. Okay. So the very first thing is you're going to want to do is obviously a chart review, right? I would go back, look at the original H&P or the most recent H&P, the latest kind of progress notes, obviously a cardiac note, possibly even a pulmonology note if they're seen. Your cardiac note should have the cardiac clearance or the risk stratification in it. So you can see that, but super crucial to kind of look at the big picture of this patient. Okay. Second thing is looking at all the tests. Okay. Looking at echoes. You can even look at a previous echo and the most recent one and then a previous one to see if there's been any major changes. Has this patient taken like a dip or anything? Have they improved, right? So looking at least one echo, but even looking previously would be really good to get a really good picture of this patient. Okay. EKG, obviously, most recent EKG, trending their labs over the last few days or looking at the most recent labs. This patient would definitely need to have labs this wouldn't be we had labs 30 days ago. No, like we need really recent labs in this patient, especially looking at kidneys, especially looking at the H&H, that this patient is not going to tolerate any type of hypoxemia as well. Looking at blood sugars, what are their blood sugars normally running? PFTs, are there any pulmonary function tests that were done recently, if available? And then obviously medications. What are they taking daily? What have they received that day if they happen to be in the hospital? Albuterol, blood thinners, other inhalers, cardiac medications, right? Pain medications, even looking at all of the things this patient could be on. Okay. I didn't do meds this time because we could do a whole deep dive into meds, but we're going to talk about these histories and the anesthetic implications, which is going to be really helpful. And then number 3, have they received anesthesia before? Right? It's always good to look at someone else's roadmap to see what they had before, how it worked. Like that's why documentation is so important. Like to always leave good notes, little love letters in your charts for other anesthesia people to follow and see what was done. Okay. And then now that you kind of have this, you have that picture of what does this patient look like right now, or have they been declining? What have you, right? What's the best plan for this patient at this time with the information that you have, with your experience, and also phoning a friend, right? Being able, I have no problem walking up to my colleagues and asking question. Hey, I'm thinking this, what do you think? Right. Or have you seen this before? Have you done? I have no issue doing that. Right. I love hearing what other providers do and getting their ideas. Right. Right. It's never about me. It's never about you. It's about taking the best care of patients under anesthesia. Right. We are becoming their autonomic nervous system. Okay. So what we're going to kind of do is we're going to go through like basically all of the quick inventory kind of her conditions. And I do just want to say that, guys, this will get easier. Care planning will get easier. Like, I know you guys feel like you're drowning in diagnoses and how they match with the anesthesia and how like, it feels like so much. And oh my God, how am I ever going to know any of this? But you will, because we have all been there. And I promise you, you will be able to do this in like 10 minutes, right? You just know what to do. So just trust and know that it will come. Okay. But let's go through it. So the first thing, history of post-op nausea and vomiting, okay? Biggest thing I could say before you give Zofran is to check the QT on that EKG. Make sure they don't have a prolonged QT or anything like that. Decadron may or may not work, depending on the type of glucose control they have, something to think about. Reglan could potentially be an option for this patient, maybe some Pepcid pre-op. You can think about like 12.5 or 25 of Benadryl potentially. So using different things. Again, I'm obviously concerned about this. I don't want this patient to get sick, but I'm really concerned about perfusion and ventilation more than anything else. Okay. So those are just some things to think about. And again, with the Benadryl, I love a little Benadryl. Even if I have like some MAC cases, give a little Benadryl, makes them a little sleepy, or patients have a lot of allergies, I tend to like slip that in, just like a little side note there. Okay. As far as, we're going to jump to high blood pressure really quick. What are the blood pressures been running? Where does she like to run? She or she like to run? Where's the last time they took their medications, right? You definitely, again, you want that clear picture of where does this patient live? We do not want to rock the boat on this patient. Okay. And here's why. Dilated cardiomyopathy. Oh, I forgot to put that on here. This patient also has diastolic CHF as well. Okay, so you kind of get dual there, right? Because when you have a dilated cardiomyopathy, you have a dilation of the left and the right ventricles, right? You're going to have impaired systolic function just in general. And then again, this patient's got like another diastolic dysfunction on top of that as well. So we've got impaired squeeze, we've got impaired filling, okay? And a lot of times what these patients present and they look like dyspnea, fatigue, ascites, peripheral edema, arrhythmias, right? So when you see the patient in pre-op, again, looking at that cardiac note is going to be helpful, but looking for any of these acute worrisome changes, okay, are these present, okay? So with this patient, we want the least depression, myocardial depression as possible. We want to avoid tachycardia and we want to avoid really big dips in that blood pressure, right? We want to maintain adequate preload. We want to prevent really big afterload increases. So with a patient like this, gentle. And like I said, we're talking about cardiac right now. We're taking one piece at a time, and then I'm going to bring it all together for you. Okay. So gentle, not a lot of cardiac depression. Okay. A-line. Do we want to maybe put an A-line? I don't care if it's a MAC case. I don't care what it is, right? Sometimes you are better off recent stroke patients, A-line, right? Something to think about. Okay. Then we're thinking about our drugs now. Okay. Propofol is going to drop the SVR. Our volatile anesthetics, our SIVO, our DES, that's going to cause a lot of myocardial depression. So we want to be careful with that. We want to how can we maybe give some other things to not have so much myocardial depression from having the gases up high, right? Opioids are very cardioprotective, right? I love using some fentanyl, right? You can dilute it down, give low doses. Fentanyl's great. Ketamine could increase that SVR, may cause some tachycardia. And also with these patients, they're going to have like a slow circulation time. So you really got to give and you got to wait a little bit because they got slow circulation time. Okay. And then other things to think about is inotropes. You might need some inotropy support for this patient. Keep that in your back pocket to support that contraction. Dopamine, dobutamine. You might even want to think about some like a low dose norepi or something. Because like I said, that hypotension is not going to be good for this patient. And again, you don't want to also prevent, like you don't want to have these sudden increases in afterload either. So like even like a low dose norepi in the background is something to think about. Maybe some inotropy, things like that. Okay. All things that are in your head and in your toolbox. Okay. So then This is where things get tricky though, because we don't have healthy lungs. We don't have a healthy heart here. We also don't have healthy lungs. Okay. So pulmonary hypertension, again, looking at this patient acutely is we're going to look for things with right ventricular dysfunction. I mean, this patient already has that. But again, in general, you got somebody with pulmonary hypertension, you're looking for those distended neck veins, tricuspid regurg, a gallop, enlarged liver, ascites, peripheral edema. Why do I keep saying edema? Okay. So things like that. COPD, short of breath, right? How's their ventilation? What are they like looking like? This patient is on 4 liters nasal cannula. So we know the lungs are not in good shape. Okay. Probably from both cardiac and COPD standpoint. Okay. So how do we want to manage these things is obviously we got to keep them on oxygen. We have to also think about, possibly elevating that FiO2, considering the stress of surgery, loss of blood, things like that. You want to avoid increasing that PVR, right? So a lot of anxiety, uncontrolled pain, obviously the SNS response, right? We want to keep that at bay. Again, avoiding large swings and changes in the SVR and the contractility, because we need that RV to work as best as possible so we can maintain cardiac output in this patient, right? Hypercapnia, hypoxia. We don't want none of that. It's not going to do us any favors. Okay. And again, looking at that echo to see what are those chambers looking like is going to be your biggest thing to kind of give you a peek into how nervous you should be. Vasodilators for pulmonary hypertension could be helpful. PDEIs, PDE inhibitors, nitric oxide, and even like some norepi would be helpful for some support here as well. Okay. And then with the lungs here, we also worry with the COPD and the issues, opioids, we kind of worry about respiratory depression, propofol, respiratory depression, right? This patient is not going to tolerate hypoxia. They're not going to tolerate it at all. And that's another thing too, is like, what is their pulse ox normally one? Where do they like to sit on the 4 liters nasal cannula? If the patient is getting up and moving or sitting up or anything like that, what does that look like? How far down does it bring it? All good things you want to know before they get on your table. Okay. Benzos could actually be a really good addition for patients like this. Okay. And again, you're looking for any signs of right heart failure, arrhythmias, very bad arrhythmias in this patient. We want them in sinus rhythm, right? Consistent hypotension. We do not want that at all. We don't really need hypotension. Okay. Because this patient's just not going to tolerate that as all. And again, this patient is bedridden. And so on top of all of this, we have no meds, right? We have no, like looking, at least if cardiac patients, the biggest thing I say to assess in cardiac and pulmonary patients is their meds. Are they able to go grocery shopping? Can they get up a flight of stairs? Can they walk a block? Can they house clean? Can they cook? Can they do whatever, or can they not? Because that is the biggest predictor. If these patients cannot function without shortness of breath, chest pain, getting tired out, they usually are not going to do well under anesthesia. Okay. More at risk for not tolerating the stress of surgery. Okay. BMI, right? So morbid obesity. What are we worried about? Airway challenges, securing that airway. Is there sleep apnea, right? Ventilation issues we worry about under anesthesia, like we just talked about before, any respiratory depression, issues potentially with positioning, depending on the position of surgery. This will be supine, but other situations, right? How are we going to position this patient safely? What is it going to do to my ventilation, especially if we have to do T-Berg? And now we've got all this abdominal pressure pushing into the intrathoracic pressure, all things to think about. Okay. Drug dosing. We don't want to underdose. We also don't want to overdose. So the rule is start low, go slow. You can always give more, but you can never take it back. Okay. Hypothyroidism, not my biggest concern. I mean, obviously make sure they're taking their Synthroid or whatever is they're on, checking the levels, blood pressure. Again, I'm not really going to like freak out about this. Okay. Sjogren's, like I said earlier, I have a whole video talking about that. So definitely go check that out. It's somewhere on the page here. But basically dry eyes, dry mouth is the big thing, positioning issues, things like that is being very careful with skin, mucous membranes. They tend to be very dry. Okay. Fibromyalgia, what kind of pain meds are they on, right? Do they have a tolerance to pain medication? That could be an issue we could run into as well. Positioning issues, etc. Where are they having their pain? Getting them positioned appropriately is always something to think about. And then diabetes, like we said earlier, checking those blood sugars, any risk of gastroparesis, how long have they been NPO for? Do they have any neuropathies? If there's any neuropathies in the lower extremity for this particular case, that could definitely be in your favor, as there's not much feeling there, but again, careful with positioning. They could have some autonomic neuropathy as well, which you can see labile blood pressures, especially under anesthesia, and might not be super responsive to pressors and things. All right. So those are all the things that one day when you are an expert, you're just going to be like, bing, 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 right? It's going to just be, you're going to just know it. It's going to click. Again, I didn't go crazy in depth, but those are kind of the major things that you want to be thinking about. Okay. So number 4, what are we doing? What's our plan? What is best now that we know all of this, right? This is the job, right? This is the risk first benefit kind of job. And I think the most frustrating part about learning anesthesia is everybody does it differently. And there's a million ways to do things. Do it your preceptor's way and make them happy, right? Make them happy. But it's challenging because, again, you guys, this is the job. What's the best plan for this patient at this time with how they are presenting right now? Okay. So, spinal. How do we feel about spinal, guys? Spinal for this patient? Maybe, right? Maybe. Personally, I didn't want to do it. A couple of reasons for the feasibility. Very, very difficult to do. Very difficult to position the patient for this as well. And again, if you get a nice dense spinal, that loss of that sympathectomy and that risk of hypotension is kind of scary. But again, I mean, somebody else could do a spinal, put them on some low-dose norepi or something like that. You could even do a lidocaine or isobaric spinal. You don't even have to do a, oh my God, I didn't think of the word, hyperbaric spinal, right? You don't have to do that as well. It's definitely an option, and you kind of load up on the benzos and the Versed, but I wasn't totally sold on the spinal. I was like, nah, I don't really know about all that, right? General anesthesia with an LMA. Depends on the airway, right? I love LMAs. I use LMAs for just about anything, everybody, albeit a few reasons I don't use it. LMA, but really depends on, again, what's the position for this one. At least we have access to the head. You're going to be supine. But other things, maybe not. If it didn't seat well, I definitely would take it out, not play around. Like you definitely would have to have a good seated LMA, a decent looking airway, right? So it depends on the neck size, the head size, things like that. Positioning. But again, general, we're going to use those really depressive gases. Not totally sold on that either. I'd like to avoid manipulating the airway if possible, but at least with an LMA, I could keep the patient breathing, and then you could use like some pressure support to adjunct them, right? Pressure support's like a bra. It just supports the breath. It supports what's there. Okay. But again, I don't know. Wasn't totally intubation. Really did not want to have to intubate this patient because, again, I cannot promise this patient that they are going to be extubated afterwards, right? And again, it depends on what they look like now. Somebody else who's active and moving and this and that, different story. This particular situation, not super comfortable intubating. If I did not have to, I want to avoid it. If I have to, then it is what it is. And again, a lot of anesthesia providers would have just been like, I'm just going to secure the airway, forget it, right? We're all different. There's no really right or wrong answer, right? But again, I just hope you're just kind of can hear my thought process. And again, I would love to hear y'all's thought process below, right? Love to hear it, right? I love learning. But wanted to avoid it, right? Again, what if I have issues securing the airway, issues ventilating, hypoxia, increasing PVR, right? It's there. Don't love it. Don't want to have to do it. And again, what about nerve blocks? We talked about regional spinal nerve blocks, right? Regional is a great choice for people who have a lot of comorbidities, all right? So here's what happened, y'all, is ended up doing a femoral block, okay? Fem and sciatic are great for BKAs. Unfortunately, could not visualize the sciatic nerve, and so ended up just doing saphenous, essentially adductor canal, right? Really wanted that sciatic though, but it can happen. And again, with a lot of significant neuropathy in this particular situation, it does help. And now again, with the BMI being what it is, you can also expect regional to be challenging as well. So there's also that, but at least I can say I tried the least invasive, right? I did learn though, is that when you have somebody who has a lot of excess skin and tissue, is pannus retraction, especially doing the fem, and even thigh retraction can be extremely helpful when doing that. Even tap blocks, things like that. Always like think about the traction, like pulling back. It actually does help you get your regional. Okay. And then again, wanting to avoid the intubation, but also if you have a patient that's super anxious and whatever it may be, right? Benzos, like I would not, I mean, I know with the BMI thing with benzos, it can be kind of scary, but again, I don't want to like amp this up. So benzos are a great way to bring it down, some Versed, right? 2 milligrams, see how we do. Can always maybe give a little bit more, 0.5, 1 increments, depending. Ketamine, I know we said with cardiac wise can be kind of like iffy or scary. Give a little bit of ketamine, right? I love ketofol. You can mix it up. You can just give for this. I kind of want control of everything. So a little bit of Versed, maybe 10 milligrams of ketamine at a time. You can dilute it down, or maybe if you get the sticks, so give like 10 milligram increments. What does my blood pressure look like? Where are we at? Again, where are the baselines at? Right. But again, for me, at least, the not intubating, I'm going to use a little ketamine, going to use a little, right? Small boluses of propofol. Some people might even avoid propofol. Precedex is great too. Using a little bit of Precedex. Either one is great. Again, want to be careful with that bradycardia, right? We do not want to drop. Also, we don't want the patient super Brady. We don't want the patient super tacky. And again, they might be like in the 60s or so like that, but you do want to be careful. So again, propofol, Precedex, just be careful, just little bits at a time. Give 1 to 2 cc's of propofol. Give like 2 mics of Precedex, right? Just little bits at a time. Okay. If the patient starts coughing or something like that, has any airway irritability, and even in general, if you want to add a little opioid in, dilute your fentanyl down. Like put it in a 10 cc syringe, dilute it down to 10 mics per cc, and give a little bit at a time, right? And all of those things together work really well. When you're doing the block, if you wanted to set up quicker, you can use a little bit of lidocaine, or you can use bupivacaine, and you just have to kind of wait for it to set up a little bit. Obviously, ketamine really helps because you're totally just kind of like out of it or whatever. But again, that's what I did. It worked extremely well. Scenario is a little different, obviously, to protect privacy and things like that. So not totally what the scenario was. But essentially, yeah, ketamine, prop, Versed, a little bit of fent, right? And guys, this is the job. There's no perfect way to do anything. There's the way that you make right. There's the way that works with your team, with where you're at, with your comfortability, with what's best for the patient. Ask for help and opinions. Stay on top of your CMEs. I love always going to conferences, 1 to 2 a year, learning new things. Look up articles. Stay in touch. Stay within in the profession, right? How can we best serve our patients? And then also with somebody like this who's pretty sick, talk with them, talk with the family. I am always I was like a trauma nurse. So I can have hard conversations, right? I grew up in the street. I did palliative care and I did trauma. So I don't enjoy it, but I can have really hard conversations with people and connect with them. So being realistic, being very honest, show them that you are concerned for the risks, right? Like these are the risks. There is a concern there, but I am going to take the best care of you. I'm going to assure you that we are going to do our best to minimize those risks. Talking with families of the different options, letting them in on the conversation to weigh them, right? Like bringing them in if you can. And then again, if the patient might end up intubated, I say that is the risk. That is always the risk when you're getting anesthesia. That's always the risk that we're going to have to secure the airway or something happens, right? And then letting them know, I might not be able to pull that tube out. And you might be intubated and sedated in the ICU and having that conversation, right? So this is the job, y'all. Okay. All right. I hope that was super helpful for you. If you have any questions or anything, please drop in the comments below. My email, all my stuff will be in the notes below, and I look forward to connecting with all of you. See ya.